in the community. Please give it up for Dr. Hotta.
Hi, thank you very much for inviting me to the Real and Innovative Conference. I'm not an expert in public health, nor in palliative care. Then, why am I here? You know later. My major academic achievement belongs to the care work, human resource management, especially in care sector, and community-based integrated care policy, with focus on securing adequate quality and quantity of care. I'm much involved in policy discussions through various memberships, for example, in National Council on Social Security and so on. And at the same time, I have been a care worker as a home visiting helper from my junior high school days till now. After university days, involved in or sometimes organize or facilitate social action or transition projects with vision of activating human capacity of renaissance in care through bridging various boundaries, promoting dialogues, knowledge management, and collaborative innovation. Dementia is one of my area of both actions and research. Today, I would like to start from international comparison on national dementia strategy with focus on palliative care. Originally, not scheduled to include this part, but after the arrival, took a look at the book, I added this part. And then go into the Japanese context, transitioning long-term care overall, national dementia strategy, and then introduce challenges in Fujinomiya City as one of the best practices in local development. When Mr. Jeremy Hughes, CEO of Alzheimer's Societies UK, has come to Japan in 2013, I brought him to Fujinomiya City to exchange ideas for dementia-friendly community and social inclusion. I consulted Jeremy about further exchange and collaboration between Fujinomiya City and some UK cities to promote dementia-friendly community after the visit. He suggested Plymouth and immediately linked Mr. Ian Sherrill, who actually will come here this evening to me. Ian invited me to the third Plymouth Dementia Conference last January. Then it brought me here in Bristol today. So, now I would like to start from international comparison, mainly through introducing my colleagues' work. Comparison on national dementia strategies with focus on palliative care, which came from the discussion I was also involved. This slide shows a definition of palliative care by WHO. Probably you are very much familiar with. At this point, palliative care usually meant palliative care for patients with terminally cancer. Then, as you well know, palliative care has shifted its focus over the years. Now it takes a longer view and a broader scope to help patients with a range of conditions and their families. In 2011, WHO Europe published a report titled Palliative Care for Older People, Better Practices. The report stated that in the past, palliative care was mostly offered to people with cancer in hospice settings. Palliative care must now be offered more widely and integrated more broadly across healthcare services. The report indicated 3 examples of good practices for older adults with dementia. Recently, the European Association for Palliative Care published a white paper that defines palliative care in dementia with 11 domains. Are you familiar with 11 domains? Yeah, thank you. The domains are composed by the basics of dementia care, such as person-centered care, communication and shared decision-making, setting care goals and advanced planning continuity of care, prognostication, and timely recognition of dying, avoiding overly aggressive, burdensome, fatality, and so on, so as well as medical issues. The figure is cited in the white paper and represents a model of changing care goals and priorities throughout the course of the dementia. It suggests prioritizing of care goals that may apply at the same time but have variable relevance to different stages of dementia. Improving quality of life, maintaining function, and maximizing comfort, which are also goals for palliative care, can be considered appropriate in dementia throughout the disease trajectory, with the emphasis on particular goals changing over time. Then, they evaluated the contents of national dementia strategies from 14 countries with a focus on palliative care content using the white paper. Palliative care contents were not explicitly referred in the 8 of 14 countries. All countries lack prognostication and timely recognition of dying and spiritual caregiving. 3 countries, England, Northern Ireland, and Sweden, had an independent section on palliative care or end-of-life care. The other 3 countries, Scotland, Finland, and Australia, had some sentences on palliative care. Scotland is characterized by the right-based care that is linked with palliative care in dementia. Finland's strategy illustrated a narrow view of palliative care in dementia. Palliative care becomes relevant for people with dementia when prolonging life is no longer meaningful. This statement contradicted some recommendations in the EAPC white paper. The other 3 countries, Japan, Wales, and South Korea, had also some sentences on end-of-life care, not palliative care. The Japanese strategy may reflect the paternalism in clinical practices in Japan, where there is no legislation on advanced directives or care planning. In Japan, patient autonomy is not firmly established, and there is controversy about withdrawing or withholding aggressive treatment. South Korea's strategy is also focused on prevention and treatment of dementia, and regarding dementia in its early stage as a curable disease, and its progression as preventable. This March, in the first WHO Ministerial Conference on Global Action Against Dementia, the Worldwide Hospice Palliative Care Alliance published a palliative care and dementia statement. It cited their work and called for palliative care in national dementia plan. I regret to say that this was 2 months after from the announcement of new Orange Plan, National Dementia Strategy in Japan. Dr. Nakanishi, first author and co-authors, are very willingly promote their international collaboration on dementia care with focus on palliative care. So, if some of you are interested in, please just email me. And I promise to link Miharu, Dr. Nakanishi. Now I would like to focus on Japanese context. Japan's life expectancy is the highest in the world. And we experience most rapid aging. The ratio of 65 plus reached 7% in 1970, much later than European countries, but now 24%. And the traditional source of support, the extended family, has been and will be declining steadily. So we introduced long-term care insurance system in 2000, financed one half by taxes and one half by premiums. Users pay 10% charge for the service, regardless of their income. In this system, everyone 40 plus pays premiums, and everyone 65 plus is eligible for benefits. Younger disabled people are covered by a different system. Character of the Japanese models are comprehensive benefits for frail older people and hybrid system, social insurance like Germany, all services no cash like Scandinavia, an integrated system, and moderate cost with spending growth under control, hopefully. After the several schedule reforms shifting to prevention-oriented and community-based system, it covers home care, daycare, short stay, residential services, facility services, and community-based services. Usually, a care manager is assigned to a client to coordinate services, depending on assessment. Community-based services designed by municipalities has been innovated and explored gradually these years, expecting to promote aging in place, even if people get dementia and or living alone. One is combination between home care, daycare, and short stay, which is provided by the same staff and managed within the facility. We also finally introduced round-the-clock care with close collaboration between home care and home nursing as a community-based service. Not only in Japan, but in many countries are in transition period in care. Because of the demographic change and disease structure change into chronic and multi-morbidity. Then, the definition of health or concept of support has been shifting from cure to care, medical model to ecological model, much value on quality of life. On the other hand, most of our care systems lack of continuity, which decrease quality of care, increase emerging usage costs, and we are facing severe shortage of care workers. So, we have been trying to increase resilience of the community, which could enhance quality of care of people who need care, take care, or others lowering resources through activating capacity of people and the community. The slide shows our vision toward community-based integrated care system. Currently, there is no gate opening GP general practitioner system, no clear role sharing between primary care and secondary care like in UK, in Japan. Free access to any clinics or hospitals, which is of course sometimes burdens, timely diagnosis or continuity of care for people with dementia. Now we try to strengthen multidisciplinary primary care, including educating general practitioners. Allocate medical resources intensively to the highly acute phase care and the community-based integrated care system, which provides housing, social, and healthcare comprehensively is set up. Then anyone can receive appropriate medical long-term care services, regardless of where they live. So, our challenges are promoting aging in place through community-based integrated care, which is common in most Asian countries. Under this context, measures for people with dementia were positioned as part of priority. And the Ministry of Health, Labor and Welfare published a 5-year plan started in 2013 for promotion of measures against dementia called Orange Plan, which is regarded as National Dementia Strategy. In 2012, 1/4 of age over 65 is estimated to live with dementia or mild cognitive impairment. 4.62 million, 1 in 7, are people with dementia. And it is predicted to become 1 in 5 in 2025. Here is a brief history of dementia care policy in Japan from 1980s. We can say there are several turning points. One of them might be this. In 2008, the national government published a report of the emergency project. The report stated that the public long-term care insurance system, which introduced in 2000, covered most persons with dementia, but a lack of early diagnosis and coordination between health and social care services caused some unsuccessful cases. Unsuccessful cases included individuals with earlier onset dementia who didn't have access to care services, and those with severe challenging behaviors who are admitted to psychiatric wards because of unavailable community care support. The report suggested that international comparison was required to standardize dementia care in Japan. Till now, there have been continuous national projects on international comparison of national dementia strategies, which I have been involved from 2011. We reviewed current and future issues of dementia and agreed that we need to change reactive to proactive to realize a society where our own will shall be respected and we can live in familiar community as long as possible, even when suffering dementia. There were 7 measures in original Orange Plan, launched in 2013. One is every municipality is promoted to develop dementia care pathways within a few years. The second measure, try to explore initial stage intensive support team learned from memory service in UK. The third measure, improve healthcare and social care services. And fifth one is promote dementia-friendly communities, including Experience Dementia Cafe, which we introduced from the Dutch experience. The sixth measures, more support for people with younger onset dementia. And acceleration of human resource development. These measures include many training programs for anyone. From 2005, hopefully you are familiar with Caravan, or you have been listening to the story about dementia supporters in Japan, and for long-term care professionals, for doctors in the community, and for doctors and nurses in general hospitals. When promoting integrated dementia care, we believe normative integration is very important. These years, we discussed principles of dementia care again and developed new dementia care models. And started dementia life support training, originally for multidisciplinary professionals to promote mutual understanding. But it could be the nice training for everyone, including persons with dementia and carers, to share the principles and each of the goals. We see movie of 75-year-old person with dementia and then 70 years and discuss what could be done from each of the participants. So it takes only 4 hours. In January 2015, the Japanese government announced the new dementia plan, or New Orange Plan, to replace the former Orange as comprehensive strategy to accelerate dementia measures. The revised plan consisted with 7 pillars and shares the basis with former Orange Plan. The first, early support. The second pillar is improving ability of care providers. And the third pillar, coordination of medical care and long-term care. The fourth pillar, risk reduction. And fifth pillar, cure. 6 is dementia supporters, and 7 is safety. The 3 main domains are coordination of medical care and long-term care, and research for prevention and care, and age in dementia-friendly community. But thanks to the global trend, especially inspired by the G7 legacy event in Tokyo last fall, we were glad that finally our Prime Minister Abe showed political leadership in dementia care policy, which we have been long waiting for or pushing for to make our measures a real national strategy. Now, I would like to introduce continuous innovations toward dementia-friendly community or social inclusion in Fujinomiya City, which is recognized one of the best practices of dementia-friendly community in Japan as a case of engaging community. Fujinomiya City is located at the foot of Mount Fuji, a World Health Heritage. A population, as you see, has a rate of 65 plus is 23.6%, and the number of people with dementia is 3,000, and the number of care remains 250. And dementia supporters, there are many dementia supporters, 9,000 dementia supporters in the community overall. There are 3 principles of dementia care policy in Fujinomiya City. Starting from people with dementia and carers' needs, creating tailor-made network around each of them, and harmonizing individual support network and community care network in Fujinomiya City, not making dementia-specific network, and which community care network, community involvement through focusing on dementia care. There are 4 phases, and first phase was creating social dialogues, starting from Mr. and Mrs. Sano coming to the Community General Support Center. Mr. Sano was diagnosed as dementia in his 50s, and in 2008, Mr. and Mrs. Sano came to Community General Support Center in Fujinomiya City, and they decided to try to make them studying in workplace in the first phase, and then going to promote them, Mr. and Mrs. Sano, to speak in the public from 2009, and then more people involved to make their quality of life more better quality of life from 2010, and then into peer support from 2012. And then in 2013, Mr. and Mrs. Sano became caregiver mate. So now they are very active in supporting people with dementia and carers also. The second phase is sharing the social issue as our issue in the community, raising awareness, deliver basic information and knowledge with local carers association, with local citizens, with local long-term care service providers, with doctors, with various stakeholders, with schools. With local carers association, they hold workshops to share burdens, problems, and solutions. With local citizens, promote dementia supported programs, starting become happening with long-term care service providers, all care workers surveyed to sort out issues and training. And with doctors, established dementia support medical care providers network committee. And with various stakeholders, connecting findings, ideas, and suggestions between people working in the community. And with schools, they promote students to become dementia supporters from 2009. So, various people in the community began to share issues as their own issue in the community. Third phase is knowledge translation to practice not only for problem solving, but for better quality of life through team building in the community, with local citizens, with long-term care service providers, with doctors, and seminar for networking, bridging boundaries between the sectors. For local citizens, educate care families, support voluntary activities. For long-term care service providers, support training organized by Long-Term Care Service Providers Association. And with doctors, they promote doctors, become care mates, and then dementia support doctors. So, they have gradually engaged whole community, not only people affected dementia now, or care professionals, but also people living in their community. Fourth phase is continuous discussion, assist individual and community programs, intervention, and share outcomes around cases. They organize various care conferences, community care conference for each case conference in community general support center to sort out community issues, and then multidisciplinary care conference involving family, local citizens, care government, professionals, and community general support center, and local government. And Doctor Study Group on Memory Loss started in 2010, and Chief Care Managers Active Local Resources and Networking started in 2011, and Seminar for Care Managers also started in 2011. Here are the future challenges in Fujinomiya City. First two focus on integration in macro and meso level. Professional, organizational, and system integration. And also promoting network between persons with dementia and develop dementia-friendly evaluation framework in collaboration with Dementia-Friendly Japan Initiative, which I will mention later. Then, promoting social involvement for better quality of life. They studied action meeting, dementia support tourism, employment support, and Run Tomorrow event, and sports event, which everyone, including people affected with dementia, could enjoy together. Most local governments started to develop their own local dementia strategy after Orange Plan was launched. A few local governments have started prior to the Orange Plan. Here is an example from Kyoto Prefecture, though in Japanese. They call it Orange Road. Orange Road. To realize 10 I messages, which are the things. So 1, 2, 3, 4, 5, so 10 messages. And there. So they call it Orange Road to realize 10 I messages, which are the desires of people with dementia and care. The idea of I messages are inspired by I station in UK. After our effort to introduce various good international and domestic examples on community engagement, Kyoto Prefecture government are impressed to hear Dementia Action Alliance in UK I organized their trip to Primas, which is famous for dementia-friendly community, through Dementia Action Alliance. Now, Kyoto Prefecture government decided to introduce Dementia Action Alliance project in Uji City, which is also regarded as one of the developed cities in dementia-friendly community. Here is a new movement called Dementia-Friendly Japan Initiative. This is a network to promote social innovation for dementia-friendly community through collaboration between various sectors. Its origin goes back to dementia project, how private sector, business sector, can get more directly involved in issues surrounding dementia. And they have continuous future sessions on shared principles and service guidelines. In June 2014, they started Dementia Friendly Japan Summit, and they are also involved in J7 Legacy event, and they become more and more active. One of the recent collaborative projects, which I'm also involved, is Words for a Journey, which collects knowledge on how to live well when you or family member is diagnosed with dementia. Advice is given each for the persons diagnosed with dementia, the patient's family members, and for the people in society in general, on how to accept and to live well with the disease. The aim for this project is to spread and share the positive and practical wisdom of the people who live with the disease, so those who are newly met with dementia can learn and be encouraged from them. Also, the project hopes to start a society-wide and intergeneration dialogue about dementia. Now, again, we really need transition in care. When looking at chronic care model and core competencies for caring for patients with chronic conditions, summarized in WHO, which are consisted with patient-centered care, partnering, including not only partnering with patients, but also partnering with other providers and partnering with communities. And the third domain is quality improvement, and fourth one is information and communication technology, and fifth domain is public health perspective. It's clear the professionals or professionalism need to be changed from medical model or acute care oriented education. Moreover, we call for continuous dialogues. Might start from people with dementia, promote sense of ownership in the community, across the sector, across the community, individual and community issues, promote happiness in the community as a whole, and promote shared community management. It could be a good start to set up a global innovation platform with focus on dementia-friendly communities, which has been gradually progressing. Then, again, I expect some of you here remember we have better integrate palliative care perspectives into the dementia care context. As I have already mentioned, none of 14 countries addressed prognostication and timely recognition of dying. And only a few countries addressed psychosocial and spiritual support, which are also important to think of dementia-friendly or age-friendly community. No countries addressed spiritual caregiving, religious activities, or a comfortable environment for dying people in national dementia strategies now. I hope we all enjoy continuous innovation in the community, with the community, and our own lives. Thank you very much.
Now we have a few minutes for some questions. Is there any questions? While people are thinking, I would like to know what a caravan mate is.
Yeah. So caravan mate is expected to train dementia supporters.
Got it.
Yeah. So we promote a local government to select doctors in the community to be caravan mate.
Why the word caravan?
Caravan, it does mean caravan. So colleagues and so involvement more and more. It's a caravan. Caravan.
Like a train?
Yeah.
Okay.
Yeah.
And they're usually doctors, are they?
Yeah, because sometimes doctors are behind dementia friendly, more focusing medical aspect, and less focus in quality of life sometimes. That's why local government promotes doctors to become caravan mate and focus on quality of life, not medical aspect. Yeah.
Okay, thank you.
Afterwards, I work with the Gold Standard Framework. We teach end-of-life care to generalists in the United Kingdom, and we're going to Japan next month.
Oh.
An invitation of the primary care doctors there to teach our approach to end-of-life care delivered by generalist officers.
We're showing primary care conference in June.
Yeah, well, we're giving 3 lectures, I think, yes.
Oh, okay.
So I wonder, will you be there?
Yeah.
Oh, good.
Yeah, good.
That's really nice. I wonder if you tell us what one issue do you think, particular to Japan, the end-of-life care delivered in Japan, what one issue do you think we should be seeking to tackle as we have in our minds as we give those lectures? Or maybe 2, or even 3.
So when he goes to the conference,
Yeah.
what one or 2 major issues should be raised at that conference?
It's in Japan.
Yes.
To see broader perspective, not only focusing on terminally cancer, but still other people's mind in Japan focus on the cancer or terminally ill people. Also, much more people is aware. It should be more broader perspective.
Yes.
So please make their eyes open.
Hi, it's Julian Abel. Thank you for an outstanding talk. I think one of the incredible features of your talk is the enlightened policy making of government and local government. And I'm sure many of us would like your politicians to come to our country and teach them a thing or two. But we would love to know, how on earth did you manage to persuade government to have such enlightened policies about community development, public health approaches to dementia care?
Thank you very much. From my thanks to my network from my university days, I tried to continuously bridge or make link between policy people, academics, and practitioners, and make policy people go to the practice and listen to the stories from people with dementia, not only with dementia, but also patient stories and primary caregiver stories. So continuous promoting dialogue between policy, practice, and academics.
Clearly, you were really successful.
Yeah, thank you.
Julian behind.
My name's Lewis. I work on another state care project for St. Joseph's Hospice. And in line with what you just said, I'm finding it really difficult to get someone to evaluate our project. It's been running for a year. And what's interesting in this conference is we've got all these people together, and yet practitioners find it really difficult sometimes to evidence what they're doing. And I wonder if there is a way of looking at how the three parts can come together, the research, the practitioners and the policymakers, part of this conference could enable that to happen.
Yeah, thank you very much. So every country, every people, in the same, yeah. And in Japan also, practitioners sometimes need support or collaboration with academics to make their practices more evidence-based, And sometimes we organize a project which the fund goes to only when they collaborate between practitioners, policy people, and academics, and patients and care workers. Through such kind of framework, the research fund goes to only the collaborative initiative or collaborative project between many various people. And then such kind of collaboration sometimes grew.
Okay. All right, so it just remains for me, thank you. It remains for me to thank you for an outstanding talk.
Thank you.
And you managed very well.
Thank you.
So we have another session in here, don't we? So,
Really look forward to seeing you. It's we're going to be able to three places. I'll give you this. This is